Hello, my name is Naomi Plant and I'm a patient safety lead midwife from United Lincolnshire Hospitals Trust. I'm really grateful to have this opportunity to share this project that we've been working on for the last couple of years and just talk you through kind of what we did, where it came from and where we've got to now. So thank you for letting me take the time to do this. So the project that I'm going to be presenting is our epilepsy improvement project. And what I'm going to touch on today is a bit of a timeline. So where we started, how it developed and where we're up to now and where we're going moving forwards. The deep dive that we completed and some of the findings that we found. The recommendations that were made off the back of the deep dive. The actual improvement project that then was a result of that deep dive, and then our ongoing plan. And we're also going to hear from one of our advanced clinical nurses in epilepsy. So to give you a little bit of a background and a bit of a timeline as to where we've got. So back in August 2023, our local LMNS actually shared a regional safety alert following 3 maternal deaths and 1 ICU admission in the region for women who had epilepsy or a history of non-epileptic seizures. So off the back of this was discussed locally within our trust, and a decision was made that we needed to review the care that we were providing here within our trust to see if we could identify any things that we needed to improve locally to make sure that we didn't have this position that unfortunately the trust had found themselves in. So at the end of 2023, we decided to complete a deep dive and review the care for those women that had received care at ULTH during the 15-month period that the regional safety alert covered. So that was from the 1st of June 2022 to the 31st of August 2023. So that's the same time period that was covered in the regional safety alert. So following this, in January 2024, the deep dive report was finalised and we shared this through our internal and external governance processes. So we reported this kind of locally within our team. We reported this within our maternity wider team, so the specialist teams, and up to our kind of leadership. Then this went up to higher within the trust, so our MNOG system that we have in place, and then this went externally to our quality and safety meeting that is held by the ICB. So we kind of had that internal and external reporting process for the findings. This was kind of during January to February 2024, as I've kind of said there. And then in March, we decided to commence an MDT improvement project to actually respond to the findings of that deep dive report and to see what we could actually do locally to improve our services. So our very first meeting was in March 2024, which I'll show you in a second, who kind of was involved in that. And we called this the MDT Epilepsy Improvement Project. In November 2024 was then when we launched some of the initiatives that were a result of that improvement project. And this encompassed the epilepsy and obstetric joint clinic, the performer that supports that joint clinic, the new e-referral process from obstetrics to neurology and epilepsy, and also the SOP and guideline that kind of went alongside this to kind of wrap around all of that and bring it all together and support staff to know what changes were happening and how to support women through pregnancy. Also in November, we shared a progress report, again through our internal and external governance and assurance processes. And then we're here in 2025. So in February, our guideline was published. In April, unfortunately, the funding ended, which I'll explain a little bit about in a moment. And then our plan is that in June, we're going to audit kind of what's happened so far. So to take you a little bit through that, so the deep dive that we completed, we use Maternity Midway at present locally, and we're just about to move to Badgernet. So we used Medway to pull the details of all the patients within that time frame. We manually reviewed all of the care that was provided using the MIS documentation. So this was only the electronic documentation. We didn't pull the physical patient records because there's not a huge amount that's actually included in there anymore now that we're electronic. We spoke to the risk team to identify any pertinent cases through our data system that may support us on this kind of improvement journey. And then we also spoke to the library services who provided a literature review for care around this kind of topic. So I'm not going to go through all of the findings, but I just want to touch on a few of them. So what we found was that during that 15-month period, we had 35 patients that fell within the category of having epilepsy or non-epileptic seizures. 23 had epilepsy and 12 had non-epileptic seizures, and you can kind of see the breakdown here. So we looked at whether it was a current or historic diagnosis, and we split everything into all patients, epilepsy and non-epileptic, so that you could see, dependent on those findings, what was important at the time. We reviewed kind of whether they were medicated or not medicated, whether they declined medication, what medication they were on. This is the next important bit, really, is whether there was a documented plan for referral to neurology or epilepsy from the obstetric team. That was a big thing that we kind of wanted to look at and just make sure that we had those plans in place and a referral had been completed. Of those who had a referral, did they have a plan, a documented plan in place? Did they have seizures in pregnancy? If they did have seizures, were they medicated? And how many weren't medicated who had seizures? We then looked at intrapartum care, so we looked at gestations, onset of labour, route of birth and location of birth, just to see if there's any skews within that data. We looked at postnatal care very briefly. Essentially, we just looked at, was there a postnatal care plan documented within our MIS for those who were medicated and not medicated? And then we looked at neonatal care. So how well was that baby when they were born? The baby's status, whether they were, if they were from a mum that had been taking medication, and whether they received those neonatal abstinence syndrome observations, so NABS observations, dependent on whether they're on medication or not. So some of the other bits that we found out, because we weren't just looking just at this audit kind of data, we were also looking at the narrative around the care that was provided. So what we found was that with the antenatal care, 42.86% did not have a documented referral to epilepsy or neurology. And 62.86% had no documentation of a review taking place within their pregnancy from the epilepsy or neurology team on our MIS, which obviously is a huge concern because we need to be making sure that our guidelines are followed, the referrals are submitted, and that those care plans are put in place to make sure these women are safe. We also identified that we have no current combined obstetric and epilepsy and neurology clinic. So at that point in time, we would be required to refer every woman through the East Midlands Maternal Medicine Network as per their criteria, because these women would sit within criteria C, so meaning that all women needed to be referred. We identified that postnatally, 82.68% did not have a documented postnatal plan on the MIS, and 73.33% of medicated patients didn't have a documented postnatal care plan. So we weren't able to support these women because we weren't aware of that care plan that had been made, if it had been made, in fact. With regards to neonatal care, we spoke to our advanced specialist clinical pharmacist who supports us. They're a really incredible resource. Just to review whether our NAS guidelines were still up to date, whether there was any new evidence that had come out, whether they needed to be updated. And we utilised our medicines information team. And that's the plan moving forward because there was no updates actually required to our guideline. So some of the recommendations that were made, one was for early referrals to be made. So we wanted to update our guidelines to make sure that the community midwives felt supported to complete early bookings in the community to then submit early referrals to the antenatal clinic. That will then in turn support early referrals from our antenatal clinic to our epilepsy and neurology teams. We wanted to make sure that the processes for deteriorations were really clear within our guidelines, communicated and really well embedded. This was because we saw a few instances in the narrative where patients or patients' families were reporting concerns around a woman's presentation to a community midwife or to another area where they had attended, and maybe the plan that was made at that time wasn't quite appropriate. So we wanted to make sure that it was very clear what we would expect if there was a deterioration that was reported within our guidelines. We wanted to make sure that we improved our documentation. What we were finding was that we were anecdotally kind of told that referrals were being made in other ways and not through our MIS. So this could be via email, via telephone, so kind of those ad hoc conversations that there was no audit trail, there was no documentation to evidence that had happened and evidence the plans that were made. So we wanted to make sure that that was improved, and so that there was really sound communication and documentation around this for the whole team to be aware. We also wanted to weigh up the benefits of a combined neurology clinic against referring all of these women to the East Midlands Maternal Medicine Network. And we also identified that there were some women that were presenting through A&E where they had seizures or deteriorations in the presentation. And we needed to make sure that the obstetric teams were aware of these women when they were attending so that the appropriate reviews and obstetric ongoing care was provided as well. That's kind of a bit of a summary of some of the recommendations. There was more. So, what we decided to do was meet as an NMDT, which is where this project really flourished, really. We were so lucky to be able to pull all of these people together. So, myself, as the patient safety midwife, kind of coordinated the project. But alongside this, in attendance at these regular meetings, we had the risk midwife, we had the consultant obstetricians, a consultant neurologist, we had the advanced nurse practitioners in epilepsy, so our specialist epilepsy nurses. They were incredible. They were pivotal for this because they know this information and the care that should be provided and the women that are coming through so well. We had our antenatal clinic managers and the matron, the community matron, the consultant midwives, and then neurology and obstetric service managers to kind of help around the coordination, planning lists, etc. So for clinic and how those processes worked. So we met roughly around 6 weekly, and we developed an improvement plan off the back of that deep dive review and the recommendations that were made. So the decision was made to launch an obstetric and epilepsy, an obstetric to epilepsy and neurology e-referral process so that we had very clear referral processes and that kind of documentation and audit trail. So that was one of the first things that we kind of got onto, really agreeing the criteria for referral. So which women actually needed referral, how they would be managed, whether they sat with the epilepsy nurses or whether they would go to the neurologist, or maybe this was combined care, and how that referral was actually made. So we developed the referral form based off the back of that criteria that we had agreed, and then this process was put in place so that the obstetricians can refer over to epilepsy and neurology as soon as possible. So that's worked really well, actually. We've found that really beneficial, and you'll hear from Tracy, one of the epilepsy nurses, very shortly, and she talks about how impactful this has been to make sure that they're receiving those early referrals. We also decided to launch a monthly joint obstetric and epilepsy clinic. Now, there was a little bit of to and froing, how frequently we should do this, where they should be hosted, how we manage the slots, because this then takes away time from the obstetric and epilepsy clinics that are already going on. So we decided to launch based on our patient numbers that we found in the audit. 2 slots per month per site. So as a trust, we cover 2 sites, Lincoln and Boston. So we have an obstetric consultant and an epilepsy nurse for each site that hosts those 2 slots per month, and they're back to back, and they sit at they're about half an hour at the very beginning of the clinic, because these women generally are coming through and not needing scans at that point in time. And we'll talk a little bit about that in a second. We developed a joint clinic pro forma to support this clinic, which I'll show you in a moment. And then we also implemented a process for the epilepsy and neurology documentation to be added to Medway, so our MIS, because we were finding that the epilepsy nurses were potentially holding their clinics, talking to their women, sending letters, but then these letters weren't then ending up on our documentation system, so onto Maternity Midway. So we've set up a system to make sure that they are scanned and uploaded to our MIS, and to make sure that the whole team is aware of those. We also identified an MNSI recommendation. This wasn't a case within our trust, it was an external case, but we had some care involvement. So we were trust B within this report, and the report spoke about needing to improve the documentation between trusts where a woman has epilepsy or non-epileptic seizures. So kind of twofold, really. One part, we within our guideline updates that supported this, I reached out to all of our neighbouring trusts for their obstetric, epilepsy and neurology services and gained all of their contact details, and these are now included within our guideline. So if we have a patient that is receiving obstetric or epilepsy neurology care in a different trust, we know how to very easily and quickly contact those people with the current contact details. So that's all included within our guidelines. So that's from us communicating outwards. To support the communication outwards in, our consultant neurologist, or one of the consultant neurologists, is currently creating an information leaflet that includes all of our details for obstetrics and neurology, which will be circulated with our neighbouring trusts. So that's ongoing at the moment to respond to that MNSI recommendation. And then, as I've kind of already touched on, we updated our guideline to include all of these above changes, plus early bookings for the community midwives, early referral to antenatal clinic, and then those escalation processes for if a patient deteriorates. So joint clinic. So as I've said, 2 slots per month per site, hosted by the epilepsy lead nurse of the advanced nurse practitioners and our consultant neurologists, consultant obstetricians, sorry, who have an interest in epilepsy. Within that clinic, they utilise this clinic performer. Now, I've only included 3 pages of the 7 pages, but what this does is this means that the epilepsy nurses prior to the clinic can pull some of the details for these patients already, and then they can use this to support the discussions within the joint clinic. So this goes through anything. So we've got basic patient details, joint clinic details, and then we go through the obstetric and the epilepsy history and presentation. So then we can make sure that there's a very, very clear and robust plan about medications at that point in time, their antenatal care, their intrapartum care, and their postnatal care. It includes safety netting, signposting, contact details should they need it, how we would respond if there's a deterioration. And it also gives, there's a section around asking the woman and the family if they've got any concerns, questions, or anything they want to raise or discuss. So it really takes them through that whole journey. This will then be centrally, so the epilepsy nurses then follow up with a letter to the woman so that they have all of this information. And then this is also uploaded to our MIS as well, so that we have this centrally located. Obviously subject to change because we know that women's presentations change during pregnancy. But at that point in time, it's a really robust way of making that plan of care. It's working really well, actually. But what we'll do next is, hi Tracy, sorry, I'll go back. We're just going to hear from Tracy, one of our epilepsy lead nurses, so the advanced nurse practitioner, and she's just going to talk about her experience of being part of this project and the improvements that we've made. Hi Tracy, I really appreciate you coming along to do this recording for us today. It'd be really great to hear about your experience with being involved with the Epilepsy and Obstetric Improvement Project.
I know, it's an honour to be involved, and thank you for all the hard work that you've done. It was great that the epilepsy nurses in particular was very active in supporting the project and helping the design of the joint obstetric clinic templates, about the referral criteria, what information we needed. So that was a really useful exercise, and one that I'm sure is making a big difference to the women with epilepsy and that are pregnant. The key thing that I've found that has helped immensely is the referral protocol, because before this project, the consultants may get referrals from obstetricians and they would wait to see them. Their waiting times was a long time. So by the time they got to the epilepsy nurses, they were well on with their pregnancy. Blood tests may not have been done. And so now the project enables the epilepsy nurses to triage the referrals. So all the referrals come through to us. There's a set template that has to be completed. So we have a criteria of which ladies stay just under the epilepsy nurse care with the obstetrician, which is about 80% of all women, and those that will have shared care with the neurologist, the epilepsy nurse, and the obstetrician. And so the referrals are coming through to the right person as long as the IT systems are working. And we also then getting referrals very early in their pregnancy, 6 weeks gestation. We're getting these where it was hit and miss in the past. It could be when they're 28 or even more. So we're able to get in there and provide a service much quicker. And we have always, as a local epilepsy service, contacted all pregnant women well within the 2 weeks of having a referral. So we still do that, and we offer still 2 monthly appointments, either face-to-face and telephone, interlaced with ad hoc calls in response to blood results. So we're able to give them all the blood forms they'll need throughout their pregnancy, because we've got the referral early on. And then we're able to book into the joint obstetric clinic, because we can work out around the 20-week gestation to book them in the clinic. So we would book the clinic. And I know that you were going to ask me, Naomi, about what's the experience of the clinics. I have to say, because, and I don't mean to brag, but I'm going to, I feel that the epilepsy nursing service get an exceptional service to women in pregnancy anyway. So we felt the joint clinic, what else was going to be gained from that? And initially, because we had lots of women that we were booking in that were well on with their pregnancy. So initially there wasn't any benefits, because we've really done everything. But now we're getting them earlier on. We're booking all the ladies in around 20 weeks gestation. And I think certainly from my last one, where they were all early pregnancies, it was more beneficial. So they will only have one joint clinic appointment. We, as epilepsy nurses, we let the obstetrician go first, asking their questions, and then we come in. And although it may not immediately add any initial benefit, what it will do for audit purposes, it will enable us to show we've done what we've done, that we've discussed safety, we've just completed the SUDEP checklist, we've given them all the information leaflets and information they should have, that they have contact details if they have a generalized tonic-clonic seizure. So this is all documented under the one joint clinic tool, and we create a clinic letter with all that information on as well. It enables the obstetrician to be fully aware of what our postpartum plan is, and all our letters are copied to the community midwives and the obstetricians, regardless. Even if it's a conversation about their levels and it's fine, we'll copy those letters to the obstetrician. I think the while we'll show if it's been of benefit is when we're able to seek the information from the pregnant ladies themselves. What is their experiences? I mean, it'd be nice to know, did they find it daunting that there was a nurse and an obstetrician there? What was the added benefit? How was it an additional benefit from seeing the nurse alone and just discussing epilepsy? What sort of questions did it allow them to ask, which they may not have done if they were just seeing the obstetrician and the epilepsy nurse? And to see about the environment and how they felt. So I think that would be more important than anything else that we as professionals will say about it.
Amazing. Thank you, Tracy. I think you've really summarised there kind of the improvements to the referral process, and it's amazing that you're receiving them so early now so that we can really act and support those women through pregnancy. And I think with the joint clinic, absolutely, I think obviously you're doing amazing services separately already. It's great to bring them together, and so that we can have that shared understanding of what the plans are for each stage of their pregnancy. So it will be great when we do the audit, and I think absolutely bringing in the woman's voice and those experiences so we can see if actually they're finding it impactful, if it's helping them, if they can see that joined up care. So I really appreciate all of your support with this project. I'm so grateful that you've been involved. So thank you so much for your time today.
You're welcome. It's been a pleasure.
So it's really great to hear from Tracy there. And just to reiterate, I think the success of this project really has been because it's been such an MDT effort. We've had, as you saw earlier, we had so many different people involved in this, and I don't think this would have been so successful or been able to come off the ground as quick as it did if we didn't have all of those people involved from lots of different aspects, really. So I've kind of spoken through how we've got to where we've got to. It's not been without its challenges. There have been, it was challenging trying to set up the joint clinic, trying to work out the management of the clinic. There's been a few teething problems since the clinic's been launched, with some clashes in appointments, some missed appointments, some confusion around appointments. So there's definitely been a few teething problems that we've had to iron out along the way. But overall, it has seemed quite successful so far. Another challenge that we have had is that alongside this, there was some funding provided by our LMNS to support with some additional hours for the epilepsy specialist nurses. Unfortunately, that has now come to an end. And so we're in this kind of we're in a position where we need to decide what happens moving forward. The neurology team has been able to fund for an extra 7 months of the epilepsy specialist nurse, but once that funding ends, we're unsure whether we're going to be able to continue with the clinic. So our next plan is that in June and July, we're going to be auditing what's happened so far. So the changes that were made, the care that's been provided over the last, well, since November, really, the impact of the joint clinic, both from an audit perspective, a health professional perspective, and the women's perspective, to see how impactful that has been. We're going to do some capacity mapping alongside this to see if there's anything that we can do to move around the clinic, whether we need to adapt the clinic, whether there are any changes that can be made with the epilepsy nurses. So they've been providing a sodium valproate clinic as well, which was hoping to be ended, but has continued for a little while longer. So we're going to be assessing all of this to see then what we can do moving forward, if we can continue to fund and whether we have the hours to provide the joint clinic, if the joint clinic has been impactful to the point that we should keep it, or whether that should be redacted and whether we should move to referrals with the East Midlands Maternal Medicine Network. So we've got a few things that we just need to iron out, but we're going to assess the impact over June, July, and then we'll be able to make some decisions from there. So I've kind of spoken about this. So assessing the impact of the additional epilepsy specialist nurses and the joint clinics. We're going to be doing that audit in June and July. And that brings me to the end of my presentation. So I'm really grateful to have this opportunity to present to you. If anybody has any questions, would like to talk further about the project that we've done, please feel free to contact me anytime. And thank you for your time. Take care.